One. Thank
Good day, everyone. We are Group 7.1 from BSN 3B, and today we'll present our flipped classroom report on endocarditis. This topic falls under oxygenation and perfusion problems, and we'll be covering its definition, epidemiology, etiology, clinical presentation, diagnosis, medical and surgical management, nursing management, and finally, our conclusion and learning derived from this study. Definition of endocarditis. Endocarditis is the inflammation of the endocardium, which lies the chamber and the valves of the heart. It usually develops when bacteria or sometimes fungi enter the bloodstream and attach to damaged areas of the heart. This leads to the formation of vegetations, which are clumps of microorganisms, fibrin, and platelets. Endocarditis can be infective, caused by pathogens like Staphylococcus aureus or Streptococcus viridans, or non infective, which is linked to autoimmune hypercoagulable states such as lupus or malignancy. The global incidence. Globally, endocarditis is not as common as other heart diseases, but it remains a rising concern. The global burden of disease shows that about 814,500 new cases in 2021, with prevalence reaching 420,000. Mortality remained high with over 66,000 deaths recorded in 2019. The most common causative organism worldwide is Staphylococcus aureus, which is associated with severe and acute cases. Despite improvements in treatment, the absolute number of deaths continues to rise due to aging populations and better detection. In the Philippines, endocarditis is strongly linked to rheumatic heart diseases, which is still prevalent in many communities. A tertiary hospital in Manila reported an incident of about 10 cases per 100,000 admissions. Alarmingly, in the hospital, mortality rate was 36.7%, much higher than global average. Delayed diagnosis, limited access to cardiac surgery, and stroke complications contribute to these poor outcomes.
So now for the etiology and risk factors. So the endocarditis is caused by microbial invasion of the endocardial surface, usually the cardiac valves. The pathogenesis of endocarditis starts with injury to the epithelium, which allows platelets and fibrin to accumulate. This forms a nidus for bacterial colonization. Common microbes include Staphylococcus aureus, Streptococcus viridans, and Enterococci. Next slide, please. So now for the risk factors, we have advanced age, pre-existing valvular disease and congenital heart defects, prosthetic valves and intracardiac devices, invasive procedures such as dental, urinary catheterization, and IV therapy. And we also have intravenous drug use, contaminated needles, and we also have immunocompromised states, which includes chronic disease, immunosuppressive therapy. Okay, so next slide, please. So for the signs and symptoms, we have systemic, which includes persistent fever, chills, night sweats, anorexia, weight loss, and malaise. For the cardiac, we have new or changing heart murmur. It means it has a valve damage. And we also have peripheral or extracardiac signs. We have oscillar nodes. These are the tender nodules in the fingers and toes. And we have Janeway lesions, painless macules in the palms or soles. And then we have splinter hemorrhages that could be found in the nails. And then conjunctival petechiae, rod spots in the retina. And we have also complications, which are stroke, myocardial infarction or heart attack, sepsis, congestive heart failure, and congestive heart failure. And symptoms may mimic other conditions, hence early recognition is critical.
For the diagnosis of endocarditis, it relies on a combination of tests. Blood cultures are the gold standard and should be collected before starting antibiotics. Echocardiography helps detect vegetations. TEE is more sensitive, especially in prosthetic valves. Laboratory markers such as elevated ESR and CRP support the diagnosis. Finally, Duke's criteria is widely used to confirm the diagnosis based on clinical, microbiological, and imaging findings. The major manifestations include positive blood cultures and evidence of endocardial involvement seen during echocardiography. Minor manifestations include other heart conditions, fever more than 38 degrees Celsius or 100.4 degree Fahrenheit, vascular phenomena, immunologic phenomena, positive culture that does not meet the qualifications of the aforementioned, echocardiography consistent with endocarditis but does not involve any of the major manifestations. Next slide, please. For the medical management, pharmacological management involves prolonged courses of IV antibiotics, typically 4 to 6 weeks, guided by culture results. In fungal cases, amphotericin B is the standard. Anticoagulants are generally avoided as they do not prevent embolization and may cause bleeding. Symptomatic relief with antipyretics and analgesics is also given. For the surgical management, next slide please. When medications are not enough, surgery becomes necessary. This may include repairing or replacing damaged valves, removing infected prosthetic valves, or draining abscesses. Sometimes, congenital heart defects that predispose to infection are corrected during surgery.
Next, for the nursing management, next slide, please. First is infection control. Nursing management begins with infection control. We ensure antibiotics are given as ordered, obtain cultures before antibiotics, and maintain strict aseptic technique. Nurses also monitor laboratory values and clinical response to therapy. Next slide, please. Next is monitoring and support. Monitoring and support care are essential. Nurses watch for signs of heart failure like dyspnea or edema, and for embolic events such as neurological changes or limb ischemia. Continuous ECG monitoring is often required. Supportive measures include promoting rest, managing fever, and balancing liquids to prevent overload. Next slide, please. Patient education and discharge planning are crucial. Nurses stress completing the full antibiotic course, maintaining good oral hygiene, and taking prophylactic antibiotics before invasive procedures. Lifestyle changes such as smoking cessation and avoiding IV drug use reduce recurrence. Discharge plans include follow up appointments, repeat labs, and echocardiography. Next slide, please. In conclusion, endocarditis is a life threatening but treatable disease. Timely diagnosis, proper antimicrobial therapy, and holistic nursing care greatly improve survival. Nurses are central to this process, ensuring both medical compliance and patient empowerment. Next, from this flipped classroom activity, we learned that early recognition of endocarditis can save lives. Nursing care must go beyond infection control. It also includes cardiac monitoring, patient education, and long term follow up. Empowering patients to maintain oral hygiene, adhere to medications, and make lifestyle changes prevents recurrence. Lastly, teamwork and collaboration are vital to ensure successful outcomes. That's all for our presentation. Thank you so much for listening.